Hello friends. So today I'll be just giving a brief overview on this very important topic, which I'm sure will be very valuable and useful for every intensive care training as they evolve to become administrators. And it is terribly important that any ICU which is working towards establishing itself as a center of excellence, this topic becomes very pivotal, because unless we do this something called clinical audit with an intent to attain good quality performance, we cannot claim ourselves to be doing well within our ICU to make it into a center of excellence. So I believe this topic can come as a DNB question, and it was asked in some format in some time. So it's important for all the trainees to have a gist and overview as to how you do this clinical audit. So when this question is asked, or when you are embarking on this topic, you need to be having good clarity on certain steps that are involved when you conduct an audit. So there are defined steps. So nothing is arbitrary when we do an audit. So the first step is try to identify what the problem is. So when we say audit, I think the simplest example, because we need to keep giving examples, like suppose if there is a increase in the MDR infections, or if there is increase in the CAP, or not CAP, WAP, or if there's increase in the CRBSI, or there is increase in the CAUTI. So we need to first identify the problem. And only when the problem is identified, then you embark on doing an audit and quantifying what the problem is, and then taking necessary steps to mitigate it. So the second step is to define criteria and standards. So when we do an audit, always there has to be a reference standard. You keep that as a standard and criteria against which you do an audit to see whether your quantitative estimate of that problem is matching with the acceptable sort of a number that is put as a benchmark, or is it above that. So for the simple example I can give, so when we look at, say, SMR, standardized mortality rate, so we look at SMR less than 1 as a good performing ICU. So you need to have that value. Or suppose if you are looking at WAP rates, so we know that the IDSA or CDC sort of a benchmark is 18 per 1,000 mechanical ventilation days. That is the benchmark. So we need to have that number and then compare to the number that gets derived from our audit, and see whether we are at an acceptable range or we are not performing as good as it should be. So we need to have set criteria or a standard as a comparator. So that is the second step. Third step is the little easier one, which is collection of data. See, once you have identified the problem, then you have a benchmark or a standard or criteria, then you start collecting the required data and synthesize the data. So once you collect the data, that is, at least you will have an understanding what all data collections you have, data points that you need to collect. Then you need to do analytics. Obviously, you collect the data, you need to make some sense of the data. So then you have to use certain basic statistical nuances and do certain analytics to see whether the numbers that you have derived from the data is matching to the acceptable or set benchmarks that are defined. And the fifth step is, once you have the data, and if that sort of a derivative that you have from the synthesis of the data, then you need to see what correctional changes that you need to incorporate to attain those benchmarks. So the fifth step is implementing the changes based on the result of your audit. The sixth one, which is possibly seldom not spoken about or emphasized, is re-audit. Because once you implement the change, it is imperative to close the loop of the audit. You need to do re-audit if the change that you have incorporated has led to the meaningful change in the desired outcome. So these are the very important steps. If this is asked in exam, I think without writing these steps, I think anyone would know that we do not have a clarity on how we are going to do the audit. So please remember these steps, very simple, fairly intuitive for a person like me, but for a trainees, it is important just to keep this sort of a schematic representation in your mind to have a clarity. Now the question is, what is clinical audit? Clinical audit is, see, this audit topic can apply to anything you do in life, but we are talking more about healthcare. So when you talk about what is clinical audit, It is the dimension of healthcare, any dimension of the healthcare that you are delivering to the patient, whether it is attaining the set standards, whether it is attaining the sort of an acceptable benchmarks, or whether it is deriving the quality that you intend to attain, is what we need to measure. So that is called clinical audit. And, and by doing this, you are able to tell the patients and to the healthcare personnel that the quality of care that is being provided is optimal and it is acceptable and it is leading to meaningful and good outcomes to our patients. So, and the questions that should be asked is whether the care that you're providing, whether it is an optimal service and whether it is being performed to the optimal levels and whether it is leading to the improvement in the clinical outcome. So these are the two questions and the answers that needs to be portrayed or given to the patient. Because when you say you are running a best ICU or you are doing the care that is meant to improve outcomes, so you need to have measurable indices, and that's what are attained by clinical audit. So the message is any ICU, you call yourself a good ICU, you cannot claim it's a good ICU until and unless you are constantly, your ICU is performing certain audits and putting forth the number saying we are benchmarked and we are attaining good clinical outcomes because our numbers reflect the global set benchmarks. Unless we are telling that to our patients and to our own colleagues and peers, we cannot call ourselves as a good ICU. And the whole aim of doing any audit is to continuously improve upon our own performance indices, and our own intent and pursuit to attain clinical excellence comes by constantly reflecting upon ourselves, auditing ourselves, and seeing how we are performing quantitatively and qualitatively, that we are making a meaningful difference. And our whole aim and intent is to improve clinical outcomes. So this is the quintessence or the essence of the whole audit, that our audit is to reflect upon ourselves how we are performing with an intent. There is a continuous quality improvement that is happening to improve the patient outcomes and improve the type of care that we provide to our patients. So that is the clinical audit. And clinical audit, this is important from the administrative standpoint, forms an important pillar. There are 6 pillars of clinical governance, and audit becomes an important entity in this one. It's one of the pillars of your clinical governance. So when you look at the clinical governance, these are the 6 pillars. There is clinical effectiveness, clinical audit. As you see, it's one of the important pillars. Research and development, accountability, risk management, education. So any ICU, for all my intensive care trainees, you claim yourself to be running a good ICU, you need to embark on having each of these components. You need to have education and training. You need to have good clinical care. You need to have some research and development happening, and you need to have some accountability to try and see certain processes that are put in place to mitigate the errors, and being accountable for certain things that are happening, and risk management. So these are the key pillars of clinical governance. Now the question is, what is quality improvement? Is it the same as audit? So when we say of quality improvement, so when we are providing clinical care to the patients, not always we get a desired consequence. There are desired consequences, then there are certain consequences which are undesired. So because every patient we treat, not necessarily the outcome will reflect or it will happen in an expected way. There are desired and undesired, and quantifying this, measuring outcomes of this desired and undesired consequences is what leads to quality improvement. So when we say quality improvement or quality indicator, it's a screening tool to identify suboptimal clinical care. So to try and identify what are the gaps in the care that has led to undesired outcome, and plugging those gaps is what is all about quality improvement. And when you talk about quality improvement, overall, there is a separate video on my quality improvement or quality measurements in ICU. You can go and reflect on it. So here I'll just touch about it, because quality improvement is an offshoot of audit, and it is almost synonymous, but there are subtle differences which I'll talk to you about. When you talk about quality indicators, mainly divided into 3 components. There are structure indicator, process indicators, and outcome indicators. So this I have elaborated and given you details in another video. Go and look into the performance, ICU performance in indicators. So there's a separate video, you can look into it. So there are 120 quality indicators in ICU, and which are divided into like outcome indicators. Just to give an example, like SMR, mortality, or a patient have proportion of days the ICU has full occupancy. They're the outcome, or pressure source. They are the outcome indicator. So on and so forth. So you can go and look into that. And what is quality improvement? So when we talk about quality improvement, so obviously we need to ask ourselves the question. So what are we trying to accomplish when we say quality improvement? And what are the changes that we are putting in place to accomplish the improvement that we are looking at? And the changes, whether they have an influence, the changes that we have put in place, whether they have had a meaningful sort of an impact on the improvement. And for this, for all the trainings, so this is something that you need to keep in mind, which comes in the administrative circle. There's something called PDSA fabric. So which is plan, do, study, act. So always you see, friends, there is a component of study. So which means there is a constant and relentless pursuit to study and gain knowledge to make certain improvements. So it's all PDSA fabric is something that you need to adopt for establishing or for implementing the quality improvement, which is planning. You have to plan how you are going to improve the quality. Then you have to put that plan into action, which is do. Then you have to obviously study by doing audit and doing analytics and putting in certain innovations to do that improvement, and then act. So PDSA is an accepted sort of an acronym that every trainee should know from the administrative standpoint. Plan, do, study, act is something that you need to put in place for making a good quality improvement in the healthcare delivery that we do. So now the question is, I'm talking about audit. Now I'm talking about quality improvement. Are these the same? I think that is something every trainee should know. They are essentially the same. So audit and quality improvement are essentially the same, but there is subtle difference. Subtle is audit. In audit, there is always a reference standard. So there is a set criteria, there is a reference standard against which we do an audit and compare ourselves. And audit generally is long term because we look at the data over a long term, 4 to 6 months. So when I say audit, suppose you look at the whether our blood sugar levels are well maintained within the range, or we look at VAP rates for over last 6 months, so on. So these are all the we take long-term sort of an analysis of the data when we are doing an audit. But quality improvement can be day-to-day basis, weekly basis, or monthly basis. Like infection control, we look at every month we look at the infection control data. So that is more with an intent to curb your VAP rates or to curb the CRBSI rates or to curb the CAUTI rates, so on and so forth. So that's the only subtle, but are essentially the same. But any ICU which is constantly doing an audit, it means it is in the pursuit of attaining clinical excellence. So both are together. They go in tandem. It is just an extension of attaining the clinical excellence that you do an audit. So they are complementary to each other and synergize each other. So keep that in mind. Now the question is, should ICU do audit? Why get involved in audit? So I would say, as an intensive care leader, if any ICU is not conducting their audit or QI, then they are not functioning optimally, because you can claim 101 things unless you show me the numbers. How is your VAP rates? How is your CRBSI rates? How is your SMR? How is your pressure sore rate? And how is your sort of a 20 quality indicators, the key essential quality indicators, how well you are giving BTA prophylaxis, all the fast tech principles, all these are quality. If you are not adopting that, then we are breaching the whole quality improvement. So why we do quality? Why we get involved in audit? Because the primordial aim of doing audit and quality improvement is to improve patient care. So our whole effort should be to improve patient care and to take certain special interest in certain areas where there may be gaps in attaining good clinical excellence, because there are certain areas where we may not be doing well, to put in focus and to put in energy into that area so that we improve upon that particular area. So to try and compartmentalize certain areas where we may not be performing well and put in energy to make things better. And most importantly, to improve our own skill set, because by doing audit, we learn a lot and we try to look at the solutions to plug the gaps and improve our clinical excellence in those areas, and to enhance our skills. Transferable skills is something, and it helps us to maintain good time management and makes the processes more robust. So it is very important that we do audit. Most importantly, any ICU which claims itself to be good should keep publishing their work. And audits can be published, should be presented in the conferences. That will help enhance our knowledge and opens up new vistas for having certain innovative ways of providing good care to our patients. And it helps build up the CV for all our trainees who are wishing to become consultants. So if I get a person who comes and wants to be a consultant under me, I would ask whether they have done audits, whether they have published. If they're not published, it means there is no intent to do certain additional efforts to improve patient care. So it is important. And the last and not the least is for appraisal. At the end of 1 year, if they come to me and they say they have done very well and give me an appraisal, so appraisal is based on what extra things you have done to improve the patient care and to improve clinical excellence. So this is very important. And this is not I am telling. So this is all referenced, and every administrator looks into all these aspects. If I am in the helm of recruitment for my whole hospital, I would look at these aspects to see who I should prefer and who I should not prefer. And this is the grid that I would be looking at, even when I'm looking at appraisal at the end of year, whether they have done audits. And in UK, it is mandatory that everyone should be doing an audit in a year. So very important for my trainees. So these 5 things is very important. Improve patient care, focus on area where there is certain lacunae, improve your skills, and attain good time management, improve your horizons, open up your vistas, and it will give an opportunity to publish the work and to present your findings in conference, strengthen your CV, and it will help you to sort of navigate and negotiate with the administrators of the sort of a quality work that you have done to improve the care, which will help in the appraisals. And how do you get involved in doing an audit? So again, when you look objectively, there are 2 variants. One is an organized audit, and when one is a setting up audit yourself. So organized audit is not for intensive care consultants who would want to make a change, because organized audit is more for someone at a very spinal level or a new entry into ICU where you have already put up a template and he's just collecting the data for you. So the whole template is there and someone is just collecting data without much of thought. Setting up data yourself needs little bit of a skill set, needs little bit of intellect, needs a little bit of planning, and it needs little bit of innovation. So joining an organized audit or quality improvement program, the pros of this is they already have a set template or a framework on which you will work. So there's nothing new that you are thinking, or there's nothing original you are putting in place. There's nothing innovative you are putting in. The framework is already there. You are just doing an audit. So this is more for interns or the new entrants into intensive care, and you don't need much time because there's not much of your intellect or thought that you are putting in there. And the cons is there is no flexibility. You cannot put in your new innovative thoughts into this organized audit. And there is no purse because you are not coming with your own think tank there and telling them that this is what we can do. And there is no new skills because people have already put the thought, think tank is put in place. You just are executing whatever that is put in place, whatever SOP is put. So there's nothing innovative in this. There's nothing new you are bringing to the table. So this is an organized audit. So I wouldn't encourage any of my ICU sort of a consultants or advanced trainees to be a part of organized. Rather, I would expect them to come and tell me what is it they want to audit and why is it they want to audit, because they have seen a problem in certain area and they would want to do an audit with an intent to improve the care in that dimension. I think that is what will be more meaningful for me. So planning your own audit is very important. And for all my intensive care trainees, remember there is an acronym, there is a way we do this own audit called SMART. It's an acronym, SMART. SMART is be specific. What is it that you are looking at? What is the problem? What is the specific problem you're looking at? And the elements or variables you're looking at should be measurable, and it should have a set standard against which you are comparing. So SMART, as I said, is an acronym. Keep this in mind when you're doing this. So it should be measurable. A is it should be attainable. Attainable means whenever you are doing a study, I'm sure most of my DrNB trainees, we say when you're doing a study, don't look for 5 outcomes. So you look at any major study, you look at only 1 or 2 outcomes. When you're doing audit, you're only looking at not more than 2 outcomes, only 1 or 2. If you're looking at blood sugar level, whether it's maintained, look at that only outcome. You can't look at 101 variables. So when you do audit, The key thing is maximum you look at 1, 2, or max 3, not more than that. Attainable outcomes. You can't look at 10 outcomes and say you have done an audit. So A is attainable. R is it should be relevant to your clinical practice. You wouldn't want to do some audit which we are not utilizing in a practical parlance, or we are not using that on the bedside. It doesn't make any sense. You cannot come and tell me that you will do audit on some new gadget which you are introduced, saying that I will do an audit on this, which not necessarily I may be using it routinely in our patients, or you do some basic science audit. It doesn't make any sense for our day to day. So it has to be relevant, and most importantly, it has to be time bound. So remember this SMART. So when audit is asked as a question, at least you should know these acronyms which are there, and the steps in the audit. These are all objective measures which are all well defined. So, and you should be able to finish audit in a timely way so that a meaningful change could be incorporated, and re-audit has to be done to make sure that the changes that you have put in place has led to favorable sort of an outcome. So remember, SMART: specific, measurable, attainable, relevant, and time bound. The pros of planning your own is you can be flexible. You can create your own template framework. And when you say you have done your own audit, it gets more weightage in your CV. Cons is it may need more time because you're putting your own think tank, and you may have missed out on certain variables that you may have wished to capture. And it needs more meticulous sort of a planning, more clinical acumen, and more abstract thinking may be needed when you have to put in your own audit or QIP in place. So summarily, friends, audit essentially is equal to quality improvement or improving your quality in ICU. And our whole intent is to improve outcome, to do the best, and to attain clinical excellence when we are caring for our patients. And that's what audit is all about. And for audit, there are three important ingredients. The key thing is planning. You need to plan, strategize, especially when you're setting up your own audit or QI. And most important, when you have put the solutions in place, you have to do re-audit to see if the solutions you have incorporated has led to the meaningful delta or meaningful change from the existing gaps that were prevailing. Most importantly, don't stop with the audit. I request each one of you to present audit findings in any of the conferences. And India is a mecca for conferences. You have conferences literally happening every month. Go out there, present your audit, and even after presentation, don't stop it. You have to publish your audit findings, and that is where you get your sort of unit performing to attain good clinical excellence. And at Manipal, we are doing all this very regularly, and we intend to create a great centers of excellence in our own team. I think that is our altruistic approach. And all of you, I request, I think we have to take ICU to a new levels. We need to adopt this audit as a sort of a mantra for our daily functioning, so that intensive care in India has reached the next level. So that's about it, folks. So thank you one and all. So request all of you to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to read to this lecture. Thank you. Thank you one and all.